Hello there. This is Christian Cooney and Erickson Hirose, and today we will be discussing the disease spinal muscular atrophy.
Alright, so here are our learning objectives that we would like you to focus on throughout this presentation. Just a reminder that this is a CME course and therefore there will be a quiz at the end of the presentation. And these are just some of the things that we felt were big picture and would help with your focus throughout this presentation. So to start us off here, we're going to talk about the epidemiology of SMA. Now, the inheritance pattern of SMA is autosomal recessive. It is actually the leading inherited cause of infant mortality. It is also second to cystic fibrosis as the most common life-shortening autosomal recessive disorder. Now, the reported incidence is about 1 in every 11,000 births, and the carrier rate in the United States panethnic population is about 1 in every 54, and if you break that up, it's about 1 in every 47 in the Caucasian populations and 1 in every 72 in the African American populations. And there are no specific risk factors known for the inheritance of SMA. Obviously, if you're unknowingly a carrier and you reproduce with another carrier, that increases your risk of your offspring having SMA. But we will discuss later in the presentation that there are some risk factors and other things that will complicate the prognosis of the disease, once born with it. So now getting into the pathophysiology of SMA. So SMA is characterized by the progressive loss or degeneration of spinal motor neurons, which leads to a lot of the symptoms that you'll see, like muscle atrophy, weakness, paralysis, and in some cases death. So what it really comes down to is the SMN1 gene, or the survival motor neuron gene. Now this gene is found on chromosome 5 and codes for the SMN protein, survival motor neuron protein. Now, these proteins play a large role in mRNA synthesis. They inhibit apoptosis and they maintain a homeostatic environment for the cell. So basically, allow for that for health of the motor neurons. So without these proteins, leads to motor neuron death over time, and then, like we talked about, those neurologic symptoms. Now, the SMN1 gene does have a backup gene, the SMN2 gene, which also codes for SMN proteins. These two genes are only 5 single nucleotides different. They are very identical. The only problem is the SMN2 gene has common disruptions in exon 7 splicing. Now, if you remember from genetics, introns and exons are the nucleotide sequences within the genes. Introns are the ones that are spliced out when RNA matures, and exons are the ones that are covalently bonded to each other and create that mature mRNA. Now, a common disruption in splicing of SMN2 is an exon 7 disruption, which leads to only partially functional SMN2 genes. So when we get into kind of the severity of symptoms and the different types of SMA, it's pretty heavily dependent on how many functional SMN2 genes do you have? How much functional survival motor neuron protein can you produce? Now, in a lot of cases, the amount of SMN proteins that SMN2 gene can produce is sufficient to sustain survival. Um, but a lot of times patients are still left with neurologic symptoms because of the decrease in these proteins that help with the motor neuron health. Now, about 98% of patients with SMA have a homozygous disruption in that SMN1 gene by deletion, rearrangement, or mutation. So there is a link on this slide that I would like you guys to watch. Please watch it till about 2 minutes and 30 seconds, and it has a really good animation and explanation of kind of what. Like we talked about, SMA is characterized by the progressive degeneration of spinal motor neurons, which leads to a lot of the symptoms that you'll see. And here is a list of a few that are common, like muscle weakness, atrophy, areflexia. We talked about how it can lead to death, and kind of one of the biggest reasons for that is the respiratory failure or failure of the diaphragm. Now, something that you won't see here is cognitive effects. So the SMA does spare cognition, and therefore this is something that you can keep in mind when trying to differentiate between other neurologic diseases. But before we kind of dive deeper into clinical presentations and how you'll recognize SMA when taking history from a patient and whatnot, we should talk about kind of the class system. So there is a breakdown of the severity of SMA, and it's kind of what we talked about earlier with the functional SMN2 genes and the amount of SMN proteins that you can make. There is a system that has been developed to um, differentiate the severity of SMA, and it's broken down into a class or type system. So let's kind of get into that. SMA SMA is currently staged in 5 stages. You have 0, 1, 2, 3, and 4. 0 being the most severe, 4 being the least severe. Staging is pretty highly dependent on the age at which you are diagnosed. So 0 being the earliest or predatally, and 4 being the latest, anywhere from the second to third and on decade of life. Now, yes, there are these classes, and they do help a lot with guiding therapy, and they do help a lot with the predicting prognosis of the disease. But it has been shown that the disease really does span a spectrum, and there aren't really well delineated like areas of the disease. So you could be somewhere between stage 1 and 2, and there has been studies showing better ways to stage it. However, this is the most or the current accepted way of classifying SMA. So let's get into kind of talking about each class. Starting off with the most severe form of SMA, SMA type 0. This is also the earliest onset of SMA, the prenatal onset. It's most commonly recognized by mothers who will experience some fetal movement earlier in pregnancy, and then as pregnancy goes on, they notice a pretty significant decrease in fetal movement to even the point of no fetal movement at all. Um, this form of SMA has the poorest prognosis, as the infants typically will die by the age of 6 months and pretty commonly by the age of 1 month. At birth, these infants will present with pretty severe weakness and hypotonia. They're often areflexic and have facial diplegia or bilateral facial paralysis. They also often have congenital heart defects. The infants will achieve no motor milestones, and as you'll see throughout this presentation, motor milestones like being able to sit up without assistance or being able to walk or crawl or whatever it may be are pretty big markers in tracking the prognosis and the course of SMA. Other signs that you may see with these infants are fetal hypokinesia deformation sequence, which includes polyhydramnios, uterine growth retardation, and skeletal abnormalities, which include multiple articular contractions. And then you might also see some pulmonary hypoplasia. Now, these infants typically only have a single copy of SMN2, and like we talked about earlier, the SMN2 gene is very important in SMA as it is the only source of SMN proteins that you have once SMN1 is mutated. Moving on to SMA type 1, or the second most severe form of SMA. It's also known as infantile spinal muscular atrophy, or Werdning-Hoffmann disease. Now, this form of SMA presents after birth, but within the first 6 months of life. They are typically pretty healthy appearing until the development of their first neurologic symptoms, which include symmetric flaccid paralysis, weak cry, poor suck and swallow reflexes, the inability to handle their own secretions, tongue fasciculations, as well as an increased risk for aspirations. So you may notice a difficulty feeding or frequent aspiration. Now, these symptoms are all secondary to the weakness in bulbar muscles. Um, some things that you may notice on physical exam are the bell-shaped chest deformity, and this deformity is due to the weakness in the intercostal muscles, which lead to a paradoxical breathing pattern in which during inspiratory effort, the rib cage tends to move inward and the abdomen moves outward. And this leads to what you'll see in that bottom right photo, the bell-shaped chest deformity. Now, another common thing seen is the frog leg deformity, and that is the bottom left picture, and this is due to hypotonic leg weakness. Now, talking about the um, motor milestones, earlier we talked about type 0, which the patients do not develop to any point of motor milestone, or do not develop to any motor milestone, where SMA type 1, they will develop past some motor milestones, like being able to hold their head up when being held, or they could roll onto their stomachs and roll back. However, the cutoff is they do not develop to the point of being able to sit unsupported. And SMA type 1 generally have 2 to 3 copies of SMN2. Dubowitz disease, or SMA type 2, is the intermediate form of SMA. It accounts for about 20% of all cases. And as we get into the less severe forms of SMA, you can see that the age continues to go up. So the onset of, or the age of diagnosis of SMA type 2 is between about 3 and 15 months of age. Now, symptoms you see with SMA type 2 are uh, pretty much the general ones that we've talked about, like the proximal weakness that affects the legs more than the upper extremities, um, sparing of the face and eye muscles, tongue atrophy with fasciculations, areflexia, fine tremors. Hand tremors are really common in SMA type 2. Um, you have things like joint contractures and ankylosis of the mandible. Now, DTRs are decreased or absent in SMA type 2. Something that can help you differ between SMA type 2 and the other types, of course, is the amount of copies of SMN2, which SMA type 2 patients generally have 3 copies. But going to the motor milestones that we've been talking about, so SMA type 2 patients, they do achieve the ability to sit unassisted. It may be delayed, but they are able to achieve this milestone. However, they will not be able to achieve standing or walking on their own. So the life expectancy with SMA type 2 is about the second or third decade. Approximately two-thirds of patients with SMA type 2 live to about 25. This is due to the lung disease caused by respiratory insufficiency. And then another common thing you'll see is that scoliosis. Kugelberg-Willander disease, or SMA type 3, is the juvenile form of SMA. It is one of the more common types of SMA, as it accounts for approximately 30% of all cases. Now, the age of diagnosis is about 18 months to adulthood, and these patients will experience the common symptom of proximal weakness that affects the lower extremity more than the upper extremity. Some of the things that differ SMA type 3 from the other types, of course, is the amount of copies of SMN2. These patients have 3 to 4 copies. And the other thing that we've been talking about is the motor milestones. So SMA type 3 patients are able to achieve independent ambulation. They are able to stand and ambulate on their own. However, something that you need to be aware of or worry about is frequent falls. Due to the um, lower extremity weakness that they experience, falling is quite common. What I was able to find is that these patients do make motor gains until about 6 years of age, and then they start to experience somewhat of a slow decline until they hit puberty. Now, puberty has been associated with a more rapid decline in motor function. However, I was not able to find any information on why that is. It seems like, as of right now, it is somewhat unknown why puberty would be associated with uh, a rapid decline. But once these patients are done with puberty, the decline in motor function seems to slow throughout adulthood. And speaking of decline in motor function, these patients, um, like we said, are able to ambulate on their own. However, later in life, it is very common for these patients to require wheelchair assistance. So what I was able to find was that if the age of onset of SMA was before 3 years old, these patients will require a wheelchair by their second decade. And if age of onset was after 3 years old, they typically do not require wheelchair assistance until about the fourth or fifth decade of life. Now, that being said, SMA type 3 patients do have a normal lifespan. They do not typically have the scoliosis or debilitating respiratory muscle weakness, so they do not have that respiratory insufficiency and therefore commonly have a normal lifespan. Now on to the least severe form of SMA, or SMA type 4. This is the latest onset form of the disease. However, it does not have a strictly defined age. Some of the research that I found stated that the age of 30 is a good marker to separate SMA type 3 and 4. It is not a very common form of the disease, as it only accounts for about 5% of all cases, and is a very mild end of the spectrum. These patients are able to achieve all motor milestones and can maintain independent ambulation throughout their life. Uh, Unlike SMA type 3, these patients typically do not require wheelchair assistance at any point. Um, they do have a specific pattern of muscle involvement when it comes to their motor function and weakness. The muscles commonly affected are the deltoid muscles, the triceps, and the quadriceps. They do have somewhat weaker patellar reflexes. However, the remainder of their reflexes remain intact. Patients with SMA type 4 have been seen to have a normal lifespan, and finally, they do have 4 genetic copies of SMN2. So here's just a really good table that I found that gives a little breakdown of the age of onset, the typical lifespan, motor milestones, and the findings seen with each type of SMA. This is a really good little quick summary of what we just talked about. So I'd like you guys to now take the time to think, pair, and share. Um, what would be on your list of differential diagnoses when working up a patient with suspected SMA? So as you can see, there is quite the laundry list of different neuromuscular disorders that should be considered when working up a patient with SMA. Um, a lot of the more vague symptoms that we discussed fall within these or many other neuromuscular disorders. So what can we do? How do we differentiate SMA from these other neuromuscular disorders? Well, of course, history and some physical exam findings are going to help us, right? So Guillain-Barré is that ascending paralysis. Myasthenia gravis has the typically presents with the ocular symptoms, um, and less than 5% of them have proximal limb weakness. Um, Duchenne's and Becker's muscular dystrophy frequently have varying degrees of cognitive impairment, where SMA spares cognitive function. And of course, ALS has the combined upper motor neuron and lower motor neuron signs, as well as asymmetric limb weakness, where SMA is symmetric limb weakness. So history and are definitely going to help. But how about we get into some of the diagnostic studies that we can order to help us with the diagnosis of SMA? EMG or electromyography and muscle biopsy have historically been the standard when it came to diagnosis in the workup of SMA. During an EMG, a needle electrode is inserted into the muscle belly, and it records electrical conduction. So the patient is asked to contract the muscle slowly, sustained, and forcefully, and that electrode is able to record electrical activity. It'll read it and it'll present it onto what is called an oscilloscope. And an oscilloscope is that image you see in the top right corner. And what it does is it takes the electrical signals and displays it in waveforms on a graph. Um, there should be no activity when the muscle is at rest, and sometimes with SMA patients, you'll see continued activity after the patient rests the muscle. And then another thing you see with EMG is during that contraction, the um, oscilloscope will show abnormal spontaneous fibrillations and positive sharp waves. Um, and the mean duration and amplitude of the motor unit action potentials are increased. Now, I can understand this is could be kind of confusing, and if you've never seen EMG done or never seen an oscilloscope. Luckily, these things kind of have fallen out of favor just because genetic testing is so common now. So molecular genetic testing with the targeted mutation analysis is kind of the go-to diagnostic workup now for SMA because it is much more accessible and it is very specific. It's very efficient and very specific. Um, so basically what you're looking for is a uh, mutation within the SMN1 gene, and then it also can evaluate the variable copies of SMN2. So here's a little flowchart that I found that kind of shows the steps of diagnosing SMA. And one of the main reasons I put it in here was just to show that once you suspect SMA based on history and physical exam, the first step is genetic testing. So as you can see here, you suspect SMA, you go right to the SMN1 deletion testing, and then from there it kind of breaks up based on your findings.
So next, we're going to talk about pharmacologic management of SMA. And prior to 1995, the exact cause of SMA was unknown. Treatments for the disease were purely supportive, and for children with the more severe types of SMA, the lack of treatment options basically meant premature death. And even before the 1990s, the research on SMA was limited, and nobody really knew the cause of the disease. Well, that changed in 1995 when it was discovered that the deletion of the SMN1 gene was actually the cause of SMA. And since then, that led to more focused studies on potential drug therapies for SMA. And in the last 5 years, actually, the treatments for SMA have developed rapidly and extensively. So in 2016, the FDA approved the first drug treatment for SMA, nusinersen. Now, remember that patients with SMA have lower levels of SMN production from the SMN2 gene due to frequent splicing errors. Well, nusinersen is what's known as an antisense oligonucleotide, and it increases the production of SMN protein by modifying the splicing of SMN2 mRNA. However, the drug does not cross the blood-brain barrier, and therefore cannot be given orally, IV, or sub-Q, making intrathecal administration the necessary route of administration. And while it is renally cleared, there are no current recommendations for dose adjustments in people with renal insufficiency. There are several potential side effects of the medication: respiratory tract infections, headache, back pain, post-lumbar puncture syndrome, and atelectasis are potential side effects. And also, it costs about $125,000 a dose, which at that cost would equal approximately $750,000 for the first year and $375 every other year that you're on that medication. These charts show the results of the phase 3 clinical trial studying the effectiveness of nusinersen on overall survival and the probability of event-free survival, which was defined as time to death or the use of permanent ventilation assistance. So you can see both charts indicate that nusinersen was significantly effective in limiting SMA-related events while also improving overall survival. All right, so the next drug we're going to talk about is Zolgensma, which is the second drug approved for the treatment of SMA, and it takes a very different approach to solving the absent SMN1 gene in patients with SMA than nusinersen does. So, in a one-time IV infusion, a non-replicating virus containing the human SMN1 gene is administered. This virus then crosses the blood-brain barrier and transfers the SMN1 gene into the nucleus of motor neurons. The end result here is that the virus effectively adds the missing gene into the patient's genetic code, and the body can then make large amounts of SMN protein on its own. This fascinating mechanism truly is cutting-edge gene therapy, and currently there are no drug interactions that are known and no dosage adjustments for renal or hepatic insufficiency. However, there is a black box warning for an acute liver injury. So, Zolgensma is, in theory, a silver bullet treatment for patients with SMA that could theoretically be the cure for the disease. However, it is only approved currently for use in patients under the age of 2. Now, there are ongoing studies being done that could eventually lead to the approval of Zolgensma for older patients. But the other caveat here is that Zolgensma is the most expensive drug in the United States at over $2.1 million for the one administration. So even though it is a potential cure for the disease, the cost is astronomical. This diagram is a visual representation of the different mechanisms by which nusinersen and Zolgensma increase the amount of SMN protein in the motor neurons. So if you look on the top left, nusinersen relies on periodic injections of an antisense oligonucleotide to boost the SMN protein production from the SMN2 gene by altering the splicing sequence of the pre-mRNA and preventing the splicing of exon 7. Now, if you look to the picture just to the right of that, Zolgensma actually inserts the SMN1 gene into the genetic code, into the patient's DNA. This results in SMN1 mRNA and subsequent SMN protein production. Now, the rest of the diagram highlights other potential ways to improve motor function with SMA, but the focus of this picture is on the salmon-colored box. Lastly, the most recent drug approved for the treatment of SMA is called Evrysdi, or Risdiplam, which was approved for all SMA types aged 2 months or older just last August. Like nusinersen, Evrysdi is designed to modify the SMN2 splicing mechanism, which leads to the production of functional SMN proteins. Unlike nusinersen, however, Evrysdi is the first orally administered medication for SMA, as it does cross the blood-brain barrier. Now, it was approved after studies showed that it significantly improved motor function in SMA types 1, 2, and 3. It is also hepatically cleared by many mechanisms, including the CYP3A4 pathway, and people with liver insufficiency should not take this drug because of its hepatic clearance. The most common side effects are nausea, diarrhea, and rash. And in the early phases of testing the effects of Evrysdi on mice, high doses of the drug caused irreversible damage to spermatogenesis. Now, the drug company keeps the doses of the drug low enough that the risk of infertility in humans is significantly reduced, and there have been no documented cases of infertility in humans yet, but the risk is still present. So males who wish to conceive at some point in their lives need to be aware of this potential side effect. And the cost, while extremely high at $340,000 per year, was actually intended to be lower than that of nusinersen to entice those already being treated with nusinersen to change their treatment plans. So, nusinersen, Zolgensma, and Evrysdi are the 3 drugs that are currently approved to treat SMA. And because they are the products of billions of dollars in research, the cost of each drug is extremely high. Luckily, there are resources available for patients with SMA to receive financial assistance for their drug treatments. Insurance companies and state governments are slowly making changes to their policies to approve these treatments. There are also many payment plans and options with the drug companies that you can set up if you decide to take the medication. All right, so I want you to take a couple minutes to brainstorm the answers to this question. If a patient who is taking Evrysdi develops acute bacterial pneumonia, what class of medications would you not want to prescribe and why? So I'll give you a couple minutes to figure this out. All right, so I'm going to assume that you pause the video here, and I'm just going to go on and tell you the answer. So the class of medications you would not want to prescribe in a patient who is on Evrysdi would be macrolide. So for the treatment of acute bacterial pneumonia, it's common to use medication like azithromycin. Well, if someone is taking Evrysdi and it goes through the CYP3A4 pathway, macrolides inhibit that path, so you would have an increase in Evrysdi and an increase in the probability of having adverse side effects. So in regards to future research, while the number of drug treatments for SMA has increased dramatically over the last 6 years, there are still multiple pharmacologic therapies currently being researched for other potential options in the treatment of SMA. Apitegromab, for example, is a monoclonal antibody currently being studied as a possible treatment for SMA, where the protein myostatin is the target. And it's inhibited by this antibody which hypothetically leads to increased muscle mass and a reversal of the muscle atrophying process. And there are also other mechanisms being studied, like troponin activation that promotes muscle responses to nerve stimulation, or other research on the roles of cellular apoptosis, autophagy, and NF kappa B on the survival of motor neuron cells. So, since SMA is such a complicated disease, scientists are casting a very broad, wide research net in order to determine the best treatment options for SMA patients. In addition to pharmacologic treatments for SMA, non pharmacologic therapies are equally important in the management of the disease. A multidisciplinary approach is the best way to treat this disease, with providers working together to provide care for the patient. Physical therapists, respiratory therapists, psychological counselors, and nutritionists all contribute to SMA management. Respiratory complications, which are the major cause of mortality in SMA patients, are routinely monitored through muscle function tests, overnight polysomnography, non-invasive ventilation, and management of infections. Nutrition is also very important in the management of SMA. Feeding and swallowing assessments, assessing signs of constipation or aspiration, and nutritional supplementation are all necessary to monitor the patient's muscle function of the GI tract. And also in SMA patients, orthopedic complications are very common. For example, scoliosis is a very common complication affecting 60 to 95% of patients. So, orthopedic therapies are often needed. Management of mobility and muscle contractures, as well as non-invasive therapies like bracing, may be necessary, as can surgery in more complicated cases. Also, another very important non-pharmacologic therapy is exercise. Routine exercise for patients with SMA has shown to improve the likelihood of motor neuron survival, maintenance of neuromuscular junctions, as well as positive metabolic and behavioral changes. The prognosis for patients with SMA is highly variable and depends significantly on SMA type and levels of their mobility. Rates of the disease progression really vary even within similar SMA types, and that poses a challenge for medical providers in the management of the disease. With the advent of new pharmacologic therapies in the last 6 years, the ability to prognosticate the progression of the disease becomes even more difficult because the treatments can significantly improve or delay the progression of SMA symptoms. The chart on the slide shows general symptoms based on the type of SMA that a patient has, as well as their ability to sit and stand and their typical age of death. But overall, there are too many variables to accurately predict the exact path that the disease will take. Lastly, one of the most important aspects to the management of SMA is diagnosing it as quickly as possible in order to prevent the irreversible degeneration of motor neurons. And as the frequency of being a carrier of SMA is about 1 in 50 in the general population, the need for increased testing is significant. Those with a family history of SMA and those who actually have the disease should consider getting tested. Individuals with SMA and their partners may also use genetic testing for reproductive planning, as any potential children of a patient with SMA will, at the very least, be carriers of the SMN1 gene defect. Also, newborn screening for SMA is very important, and over the last few years has been added to the list of standard screening tests performed at birth in many different states. Currently, we are sitting at around 37 states that screen for SMA. The state of Oregon, however, has yet to adopt testing for SMA as part of its standardized newborn screenings. There is a bill, though, up for a debate in the Oregon legislature this year that would add SMA to its standard screening. So let's do a case study to solidify our knowledge here. An 18-year-old male presents to your office seeking help for a tremor in his hands. He has just graduated from high school, and he's worried that the tremor he's had his whole life will prevent him from pursuing a career in medicine. He reports that the tremor gets worse with intentional movement, and then it goes away with rest. He denies any numbness or focal weakness of his extremities, but does state that over the past year he's noticed increased difficulty going from sitting to standing position. He states that he assumed this difficulty was due to him just being out of shape. So his vitals are normal. Family history: his father and uncle also have intentional tremors in their hands, which are very mild in severity. Doesn't have any remarkable past medical history and is not taking any current medications. So you perform a physical exam, which is unremarkable except for the neurological section. So when you're doing your thorough neuro exam, you have no evidence of oculomotor nerve dysfunction, no facial asymmetry, normal balance, normal gait and posture, no rigidity. You do, however, notice noticeable atrophy of the deltoids and pectoralis muscles bilaterally. You notice a positive intention tremor on both hands. And when testing sensation, the sensation to touch and pain and temperature, vibration, and proprioception are all normal. You do, however, notice that the deep tendon reflexes are decreased bilaterally. You also noticed decreased strength in both hips when they flex, as well as elbows when they extend. There's no asymmetry or focal deficit, normal stability, normal range of motion, normal rapid alternating movements of the arms. But the weakness and atrophy of the muscles does cause you to have some concern. So, what would you do next? What would you do to diagnose this patient? So, the first diagnostic test to perform is an EMG, which shows decreased electrical activity with contraction of the triceps, quadriceps, and gastrocnemius muscles bilaterally. Now, the results of the EMG are concerning, and so you decide to get a muscle biopsy. When the results come back, they show muscle fibers in clusters of hypertrophied muscle fibers, as well as clusters of grouped muscle atrophy. And if you look at the picture on the bottom right, you can actually see what I'm talking about. On the left side of the picture, there are large hypertrophied muscle fibers, while on the right side, there are groups of significantly smaller atrophied muscle fibers. So the results of the muscle biopsy have you greatly concerned about a potential genetic disease, and you decide to get a genetic test. And when it comes back, it does confirm a mutation of the 5q13.2 gene, along with 4 copies of the SMN2 gene. And with this patient, it would be consistent with SMA type 3. So the next thing we have to do is manage this patient. And the first thing we do is provide educational resources and access to support groups for your patient. Also, given his symptoms and his age and weight, it's necessary to start the patient on 6.6 milliliters of Evrysdi daily, as well as encourage lifestyle changes, including increased exercise and changes to nutrition. And then, as the management of SMA is multidisciplinary, referrals to physical therapy, orthopedics, and counseling may be needed depending on the patient. And actually, this case study is my own story. I was diagnosed with SMA type 3 in June 2011, and it was during a time when there was no pharmacologic therapy available. I started experiencing some weakness in my hip flexors and in my triceps when I was about 17 years old. But I really didn't think of anything of it until the neurologist noticed it during the routine physical exam when I was being seen for my tremor. And about 3 months later, and 3 EMGs, a muscle biopsy, and a genetic test later, I was finally diagnosed with SMA, and when they finally did diagnose me, they basically said that they didn't have any treatments for me, and I wasn't offered any of the non-pharmacologic treatments either. It was basically, you can't build muscle, and it's a progressive degenerative disease, and we'll just continue to monitor the situation over the years. And that was really tough. I mean, for a 17-year-old, 18-year-old kid who has his whole life ahead of him, to be thrown with that was very emotionally stressful. However, past 6 years have been incredibly exciting, seeing the development of the 3 treatments that are currently available and giving me some hope that someday I won't have to worry about being in a wheelchair when I'm older. And I can say in the last decade that since my diagnosis, the progression of symptoms has been pretty mild, but noticeable. Standing up from the ground is nearly impossible, and I have a tendency to fall more frequently, and I'm unable to build any muscle mass, which is a drag. But back in September of 2020, I did start Evrysdi, and while I don't feel any significant improvement in my motor function, I haven't had any noticeable decreases in function either, which is exactly what I'm expecting. The picture on this slide to the left is actually a picture of the box that my Evrysdi comes in, and the picture doesn't really do it justice, but it is a massive box that they have to insulate because Evrysdi has to be stored at such a low temperature. And so every month I get just a massive box at my door that I then have to store. But since this disease was not covered during the didactic year, Erickson and I wanted to teach our classmates about the disease, as it's not only a fairly common disorder, but is also at the forefront of some amazing new drugs and new pharmacologic treatment. So thank you for listening, and I hope you enjoyed everything that you heard. And if you have any questions, feel free to reach out to me. I'm an open book about this disease. So thank you again. These are our references.